Andrea Restifo. I am the Associate Executive Director for Quality Management at Northwell University Hospital, part of Northwell Health in New York. I want to thank the American College of Medical Quality for hosting these series of quality webinars. And today I'm really excited. Our topic today is credentialing process and quality, how these two processes intersect. Today I'm with my colleagues here from Northwell. Dr. Yosef Dlugacz, who's a retired trustee and a board member for the American College of Medical Quality. He's a professor in residence at Hofstra University in the School of Business and in the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Sitting next to him is Dr. Annabella Salvador-Kelly, who's our Deputy Chief Medical Officer, Senior Vice President of Medical Affairs, Associate Professor of Emergency Medicine, and also faculty in the Donna and Barbara Zucker School of Medicine at Hofstra Northwell. Sitting next to Dr. Salvador, I want to welcome Dr. Richard Schwarz, who is Vice President of Medical Affairs, Vice President, Quality Chair, Policy and Procedure Committee here at Northwell, Co-Chair of the Northwell Performance Improvement Coordinating Group, former Medical Director at Long Island Jewish Medical Center, and also an Associate Professor of Clinical Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. And finally, welcome to my personal colleague and friend, Marianne Ambookan, who is an RN MBA, Vice President of Medical Staff Services across our Northwell Health System. Our goal today is to define the administrative and clinical processes to measure an effective credentialing and re-credentialing process to guide decisions. You will be able to gain a better understanding of the role of the system, Central Credentialing Verification Organization, how the Medical Staff Office, medical leadership, and trustees ensure an effective credentialing and re-credentialing process. We're going to show you how we perform the functions of focused performance professional evaluation and ongoing professional performance evaluation, what data we use for decision making, and what triggers the process. And in that conversation, really want to hone in on some of the red flags that we see in the process and how we deal with them. And finally, what's a really hot topic today is cybersecurity, and we want to reflect on our own security measures to protect that database and share them with you all. I'm going to turn it over to Dr. Salvador to go over the scope of the system and our credentialing.
Great. Thank you, Andrea and Yosef and the American College of Medical Quality for allowing us this opportunity to discuss Northwell Health's credentialing process and how it interfaces with quality. So to give you a little bit of background, Northwell Health is basically in the lower part of the New York State, specifically Long Island, New York City, and Westchester County. But we have been known to go a little bit outside this area. We are now starting to go into Connecticut, and we are planning on hopefully other areas in the near future. But Northwell Health currently has 23 facilities, 21 hospitals, 2 subacute nursing facilities. We have over 85,000 Northwell Health team members that work for us. There are also 2 schools that we're affiliated with, the Hofstra Northwell School of Nursing and Physician Assistant Studies and the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. And the importance of that with credentialing is because we often hire from those 2 schools, and it's really nice when we can hire from a place where we already know the individuals and we can get feedback about them and we know their training programs. So that's been a great asset to us in the credentialing world. We have over 900 ambulatory practices as well, and over 50 urgent care facilities also throughout New York, and now we're also credentialing Go Health in Connecticut. It's important to note that we have over 18,000 credentialed practitioners that our team has to vet the files for. So we're pretty large, and we keep hoping to get a little bit larger. So currently, we're in the process of possibly merging with another healthcare system, which would bring our numbers from 21 hospitals to 28 hospitals. The importance of that is that we've never merged with another health system before. So to give you a little background, when Northwell was formed, it was formed as small individual community hospitals that decided to partner together. So it started off with 2, and then 3, and then 4, and little by little, we increased by 1. We never did a merger with another health system. And when we did credentialing, it used to be very local at the individual hospitals. So we had our processes very local, but as we developed and got bigger, we felt that there needed to be a standardization, and we wanted to ensure that there was quality in the processes that we put in place to credential all the individuals that were working for us as a health system. And that is when the idea of a credentials verification organization, as what we call a CVO, came into play. And I know we'll be talking more about that. But that was one of the key processes for us in the credentialing system that helped us to ensure that we had quality embedded within our credentialing processes.
It's really a beautiful summary of the process and the structure of credentialing in Northwell. And you did mention that your process is consistent in different geographical areas, in different physicians' offices, in different hospitals. And you have to really take care of 18,000 clinicians on an ongoing basis.
Yes.
And really, the 18,000 is one number, but you have to multiply it really by 2 at least, because you do the recredentialing. So this is really amazing. So for you, Marianne, my question is that, how do you do it? How do you create a standard throughout this diverse system, and what is special about it?
What I think is special about Northwell in general is our centralized processes, not only in quality and medical staff and various other areas in our organization. I think that sets us apart from other health systems, how we work together at a system level and standardize our processes. I manage the CVO at Northwell. It started originally with getting the state to allow us to have a centralized process for credentialing. So we advocated to the state. We established our, what we call an Article 28, a licensed facility at the state level to afford us all the protections in our quality process. And that enabled us as an organization to be able to standardize and centralize the credentialing process for Northwell. Another very important aspect, I think, coming back from nursing background and the clinical side, is our delineation of privilege forms. We have a standard set of delineation of privilege forms across our hospitals. Not all the services are available at all the hospitals, but then we call it opened and closed the privileges accordingly. So not only are the files processed in a standardized fashion, our privilege forms and all the standards for specific privileges within our hospital have been standardized across our organization. And I think that's key to quality and key to patient safety. So the way the process would work is that the central office processes the applications, and we also process the privileges. I've seen many organizations where they may have a CVO or a centralized process, but the privilege forms are not part of that. We incorporated the privileges into our centralized process. So after the CVO or the central office process the files using set standards that are the same across all of our facilities, we then provide those files to the local facilities for the approval process. They go to a local chair for approval of the privileges and the file, as well as the local committees, which in our organization is the Credentialing Committee, the Medical Board, and they do then all funnel up. That we'll talk a little bit about Job Board of Trustees. Dr. Salvador will speaking about that. So in our centralized process, we meet all Joint Commission standards, all CMS standards. We are the certified CVO by NCQA, the National Committee on Quality Assurance. And we also follow all the state requirements as well as the bylaws. So having a centralized process really enables you to look at all these areas of, I consider them regulatory, that we have to follow and abide by. It's, I don't say easy, but when it's all captured in one, I feel that it's focused and we follow those. These are my rule books. When I came to manage this office, those are the first things. The Joint Commission, what are the standards in the state? And we make sure all of our processes follow all those standards. We do have a large volume. We process 3,500 annual initial appointments. We have an initial appointment team, and then about 9,000 reappointments annually as well, with a dedicated team on the reappointment side, again, all following the same processes. In our organization, because we're geographically close, we have many providers that cover more than one hospital. So while we have 18 individual providers, they hold over 46,000 appointments in our organization. That's where the privilege is different. That's where the local chairs each are approving those files. Some are very much standardized, some of our services like radiology, pathology, but there's a lot of local services as well within our organization.
I was really wondering, you're doing so, the data is huge, it's absolutely immense. And do you have quality control systems in place? It just occurred to me because you can make a mistake.
Yosef, I've worked for you for so many years, and you've been such an amazing mentor to me. We have many quality. The data quality processes, an initial file, which is one of the most important in the department, a new applicant coming into our organization, 100% of our initial files undergo a separate review of a quality process. Then we have additional quality processes embedded in the files and in the office, which rely heavily a lot on our database. We have a centralized database that we can run automatic reports, and we're constantly monitoring quality in each aspect of our process, looking at exception reports, making sure everything went to where they were supposed to go, as well as we have checklists embedded in the database, ensuring that all the files meet every single step of our process.
It's great. It's beautiful.
This is an overview of all the aspects of the credentialing process that we follow, and basically what's drives us on the requirements, whether it be a local hospital bylaw, whether it be Joint Commission, NCQA for our CDO certification, or state regulation, as well as CMS. CMS and Joint Commission pretty much are tied. And one of the most important aspects having worked with Yosef all these years and quality, I feel, is our competency assessment process. In our database now, we have a nice feature where you could actually complete a competency assessment on your iPhone, and it goes right back into our database. But what we give with every single competency, we require competencies. We have many rules around it, but if you have trained within 5 years, you have to get a competency from your program training director. You not only need 3 peers, we're not allowing just 3 people you work with. We always look for a hospital competency in a file. If you haven't worked in a hospital, we're looking for a chair competency. We want a clinical leader to tell us that you're competent in the privileges you requested. And what's key is we send those privilege forms with our competencies. So when we get that competency assessment form back, which we use the ACGME training standards, those 6 ACGME core competencies in all of our forms, and they many times comment on the privileges that the provider is asking. So if those privileges were not done in that training program, they will allow us to know it, and we may flag the file, and maybe we may need to adjust the privileges because maybe that applicant is not yet ready to perform those privileges. And the other area that's very robust at Northwell is our criminal background checks. We do fingerprinting for all our employed, as well as outside the state and within the state criminal background checks for all our applicants. And we have a very dedicated trustees that are very involved in our process. And we not only do the criminal background, if someone has a history of a criminal background, we actually ask them to provide us with their arrest paperwork and their disposition paperwork. So we ensure that what they said happened in that case is accurate as to what they were charged with, and what the ultimate outcome. So we don't necessarily take their statement, we verify that statement as well to make sure that statement is accurate. So I think, along with everything else we do, a lot of queries today out that really help us with continuous query in the National Practitioner Database. We do the FSMB, check all states' licensure to make sure there's no adverse actions, and a whole series of other queries that we do, all our primary source verification, to really ensure applicants meet and hold the quality that we would expect at Northwell.
This is great. It shows that it's really a very thorough review process and a very thorough analysis. And one outcome of this analysis is that you report this information to the Board of Trustees. And I sit on the board, and as a voting member of the Quality Committee, we make decisions together with you who provide this data. And one of the interesting issues in the process is that you identify for us the red flags. And I really love it because it's not only an interesting gossip type of information, you know, to hear about a practitioner who has a criminal background, or to hear about a practitioner who drank too much in a party and got caught by the police. Well, we like to talk about it. But regardless, there are sometimes gaps in the information, and you identify it. So you take a proactive approach for us, for the board. So, Annabelle, if you don't mind to describe the red flag process.
Sure. So I think Marianne did a great summary. Just to go back a minute, we'll get an application that comes to our office, our CBO office. It is processed, and during that processing portion, there's criteria that the team members will identify to see if there are potential files that have concerns in them, which you refer to them as red flags. Different organizations call them different things. Some people call them red flags, some call triggered files. But they're essentially concerns that may be apparent on the application that requires further questioning. Because we want to get maybe a little bit more information on that specific category. It doesn't mean that we're not going to hire that individual. It doesn't mean that we're going to deny privileges. It just means that right now we just need a little bit more information. And so we created a guidebook for all our chairs or anybody that's new to the credentialing process, that they can use the guidebook to help them with how to vet these red flags. So the team, the coordinators will identify the red flags for the chairs. They will then submit those red flag concerns to the chairs or their designee, and that individual, that leader, needs to vet that file and that concern, and then he is obligated to write a memo back to the committee, to the Creds committee, whether he's going to support or deny or not support the file. But in the memo, he needs to explain what the category is, why that issue is in there. And I provided here a couple of samples of what type of things may be considered a red flag. So items like on the peer competency that Marianne spoke about, if the evaluator checked off fair or poor, or checked off that they need further, that they had some reservations or did not recommend that individual, or if they had concerns that they put in the comment box about the privileging, that would be a red flag, and we would ask that chair to go back and speak to this peer evaluator to get more information. And we have changed privileges, as Marianne said, based on what some of these peer competencies say, because if it's coming from a program director that says that person wasn't trained to do those privileges, that's a concern. That's a safety concern. It's a quality concern, right? Because we do not want to bring on practitioners who are not competent and qualified to do those procedures. Now, sometimes when you're new to this credentialing process, and we see this with the new graduates all the time, they just start checking off boxes and maybe not reading the full description in there, and they get so excited that sometimes they're just not careful, and they accidentally pick a couple privileges that they probably shouldn't have picked. And those are easy to fix. Sometimes it may be we don't have enough peer competencies. One of the things that Northwell does is we do require 3 peer competencies for initial applications, and we require that one of them be from a supervisor or from a chair. And the reason why we're kind of strict with that requirement is because we know when there's adverse events that happen at another site, it's usually leadership that knows about those events. It's usually not your peers. So we do like to get that extra competency to ensure that there was, maybe no other concerns that that evaluator may have had. Also, a failure to disclose is also a big red flag for us, because if we find out things from your application that you did not disclose when you were filling out your application, we start wondering about your ethics, right? And why you didn't mark something on that application that you should have. So sometimes that will also be a red flag. And those failure to disclose are usually when we run our primary source verifications. We might find out things on prior data bank. It might have been prior arrests that we find out about when we did the fingerprint analysis. So all of these are vetted very carefully. And then once they're vetted by the chair, they go through the process that Marianne described of going to the credentialing committee, the medical boards, the committee on quality, and then the board of trustees. And that's sort of the approval process. What we also do, because we are large, sometimes when we know about these red flags ahead of time, before it goes to even the department, or not the department, but the creds committee, we will meet with the department and the leadership at each of the hospitals, because sometimes these individuals are applying to multiple hospitals. And they may have requests to go to 3 or 4 different hospitals. So we all want to be on the same page because we want to be standardized and consistent. So we will have a meeting, a pre-meeting, an ad hoc meeting, to get all the leaders in the room at the same time to review the application together, so everyone understands what the concerns are, and we can come to a decision together about what we should do with the file. And then it will go through the usual approval process, as Marianne said, and that we call the early alerts. After all the red flags go through the medical board, we do create a red flag report. And that is all of the vetting that has been done for each of these individual files. And that report goes to the Committee on Quality and to our Board of Trustees. And it's there that I have the pleasure of presenting each of those files to our Board of Trustees. But really, at the Committee on Quality is where we have very robust conversations. The board is very interactive. They ask amazing questions. Nobody is rubber stamping these files. And once you've worked with the Board of Trustees, I think long enough, you start anticipating what the questions are going to be. So you come prepared to those meetings because you start thinking the way they do and say, oh, I want to also know the answer before it even gets to the Board of Trustees. And the Committee on Quality not only does approvals for all of our red flags and all of our applications, but they're really a committee that looks at multiple different things when it comes to credentialing and when it comes to medical staff affairs. They also review all of our bylaw changes that we've seen. Sometimes we may bring up OPPs or FPPEs through Committee on Quality, especially if those FPPEs require proctoring and corrective actions. So we discuss all the corrective actions that require like medical board approval and action goes to the Committee on Quality as well, and we have robust conversations there. We discuss quality cases that perhaps a practitioner was involved in, and we discuss them at the Committee on Quality. So it really is the core of how quality and credentialing interface together at a very high level. Because to us, it's so important to ensure that we bring in physicians or practitioners that are qualified and that are competent, because patient safety is at risk, our reputation as an organization is at risk, and you always worry about risk management, malpractice cases, and so it is so important to have quality in everything that we do.
Right. I want to reinforce it because at that committee we get the information from you, the credentialing and the privileges, and we get the quality
Correct.
report. So if we see a physician that deviated from care in terms of an adverse outcome, let's say wrong side surgery, the first question that the trustees will ask, is this individual credentialed, competent? And this way you can merge the two files and you can give us an answer, which you do.
And
So-
we intentionally have a very low threshold for red flags, because we would really rather investigate 10 too many than miss one.
Right. No, it's amazing. Over the years, I saw the progression of your work, and it's unbelievable. I think it's reaching a pinnacle almost
Yeah.
in that area.
And I was going to say, and it's a two-way street, because
Yes.
even though we report up to the Board of Trustees, we also get lots of great ideas and communication that we feed back to our committees, and there's a downward stream as well. So
Yes.
when a member sometimes asks great questions or something that may not have been thought about, we bring that back down to all of the committees. So it's a two-way dialogue.
Yeah, because we work as partners. We're not on the defense.
Correct.
This is the idea. And this is the whole idea of accountability, to reach this level of trust in such a complex organization. So we touched upon the relationship between quality and the process of privileging and credentialing and appointment in our organizations, in inpatient and outpatient. And we'd like you to elaborate a little bit, because it's such an important topic in healthcare, is really how the two things work, how quality works in credentialing, what is the relationship, are they separate, what type of interaction, level of interaction takes place, and the level of interaction, I'm sure you talk about the EPPE and the OPPPE, and this will help us to understand the interface.
Yeah, so I personally think quality management credentialing have to be tied together, right? And we often use quality management tools even in our department, right? When we create a new change in our department, we use the quality tools of Plan, Do, Study, Act, right? We pilot something, we go back, we study it, we see if it works. We're constantly doing that in our department because we're always trying to build on efficiencies. How do we get providers onboarded faster, right? How do we decrease the time that it takes to get the application done? How do we get it through? You could see this cumbersome process that's so important, but how do we get all the files through all of these approval processes even faster? So we're constantly thinking about quality. We also have in our department our key performance indicators that are so important. We ensure that our coordinators are doing what they're supposed to do. And as Marianne mentioned earlier, we even have quality coordinators that review those files to ensure that the person who touched the files earlier did the right job and didn't miss anything, because we would not want to omit anything from an applicant's file. So quality is definitely implemented in everything we do. It's also really important because we're very highly regulated as well, right? We have the Joint Commission that comes and audits our hospitals. The Department of Health comes and audits our hospitals. One of the sessions that they often talk with us about is the medical staff session. And in that medical staff session, they want to know about our credentialing process. And so we have to have a very tight process, and they will look at our files. Did we check to identify that person is who they are? They will ask for, let me see their OPPEs and FPPEs. So FPPEs, which is a focused professional, a focused professional performance evaluation, and the same thing with OPPE. they will ask to see those documents to ensure that those individuals are competent to perform the activities. So it is so important that the two are intermeshed at all times. Once somebody goes through the Board of Approval, or the Board of Trustees approval, they go to the hospital, they automatically start an FPPE process because we want to observe them during those initial several months to ensure that they're competent. So some of them may require that they're supervised for the first operations that they do. They may look at their documentation in the charts. Are they documenting appropriately? They may look to see their procedures and were there any complications. So they go through a rigorous FPPE process. And
that's even if they're experienced elsewhere.
Exactly.
Not just for new graduates.
Exactly. And a lot of the data that comes is from quality. Quality often provides a lot of that data to us or to the chairs to do those FPPs and OPPs. And then the OPPs is important at reappointment because when you're looking to reappoint somebody, you want to go back to those OPPs and say, let me look at their data. Let me look at how many complications do they have. How many procedures did they have? Did they have enough volume that they're still competent to do those procedures? And so we work very closely with the chairs, with quality, to ensure we have data to do the FPP, OPP process.
I really like it because the more you think about it, medical errors takes place all the time.
Hopefully not all the time.
Hopefully.
Well,
We're trying to get to zero.
Some of the time.
There are different philosophical opinions about zero. Zero is a number too, by the way.
It is, it is.
So, nationwide, we are hearing constantly about different news relating to errors, even internationally. So things happen. So I'm really happy to hear that you have safeguards, basically, to control as much as possible those errors. Maybe one day we'll get to zero, I don't know. Maybe with AI, we'll try to figure it out. So this is one thing I like. The other is that the fact that young physicians, especially surgeons who are doing a procedure on their own for the first time or the second time or the third time, it's being monitored. This is great because you can prevent future problems. And I bet the surgeons don't mind, right, to be observed.
Right. Yeah, we embed it into it.
Yeah, and again, it's not just the people who are new graduates. If somebody comes from elsewhere, we may not necessarily have the same standards other places do, so we will monitor anybody who's new to our system just to make sure that we are comfortable.
So you change the culture, basically, of physicians, the way they think.
And high-risk procedures are required, like robotics. You have to be proctored, when you do robotics. So we have a dedicated committee looking at some of the more high-risk type areas of healthcare, like robotics, and they all get proctored, even if they came experienced. We want to verify that experience when they come into our organization.
That's great. Thank you very much. So the next, would like to have an example from a hospital, like North Shore University Hospital. And I'll ask Andrea if she can make a comment on the structure and process and the relationship between quality, credentialing, and privileging in your organization.
Okay. Well, as the quality lead, it's always nice to give a chair a compliment to put in the file.
That's right. We love compliments.
They like compliments. But at the same time, we have the processes around looking at individual cases. We have our incident database. We have cases that we take for root cause analysis. And we are able to work with the department chairs and provide information on these cases for the files. The department chairs have an M&M process that they really look for the education of the M&M and what to learn, and then they will trigger us for equality if it needs a root cause. So it's really a great process to know what stays in that departmental chair and what's going to come from quality. We will encourage the chairs on, here's the list of things you can put for OPPE. So length of stay, readmissions is my favorite. Complications,
Patient complaints.
Complaints, yes, we'll take the opposite of that, and the tissue review for their files, so they know that we're really trying to reduce variation and get that standardized across the system, and it's not, I don't know what to do, it's here's the menu of what you should do. And from the performance improvement plan all the way to the bylaws, it really does outline the responsibilities of our department here, as well as the department chair. What you see on this picture here is the hospital level has our own performance improvement coordinating group, which is chaired by two physicians here at North Shore. And we have every quarter, each department is reporting quarterly on standardized metrics, right? We're very big on standardizing. So we really want to know about the scope of their department, the hospital priorities, mortality, readmissions, and performance improvement that they're undertaking. And we're wanting to make sure that the information that they report to our PICG is then given to our local medical board, and that in turn goes to the Committee on Quality Board of Trustees. And quality is not sitting on the credentials committee, but quality is supporting the information that the chair can use for the files. It's for the FPP or the OPPE. We're not being the administrator of that file, we're just, because we have data on these things, making sure the chair is aware of that and can help process that through. What's really neat is what I have here at North Shore with the Performance Improvement Coordinating Group. Every hospital at Northwell has the same structure, from Performance Improvement Coordinating Group to the Medical Board to the Board of Trustees. So the Board of Trustees knows that they're going to get the information from each of the hospitals in a very consistent way and get a real sense of what's going on in the hospitals as well. And to your point, it's two-way communication. Mm-hmm. So when we have our medical board, we're getting a report from the system, often from many of you at the table here. And then at medical PICG, we're getting a report from the system and our medical board. And oftentimes it's like, let's look at risk in process and what can we learn from cases that we want to bring back to share and prevent. So it is about getting to that zero harm. It just takes a little bit to get there. So this process has been really effective, and people know what to expect. And it's almost an honor to sit on the Performance Improvement Coordinating Group at the hospital to see all this information.
And I think what's really beautiful about it is that you don't present it in a punitive way, right? It's always presented in a way of how can we do this better, and so that you develop this sort of culture of psychological safety where people feel comfortable escalating events. And to your point, when you identify something that we could have done better, it's shared across all our 21 hospitals, because it's so important for people then to go back and look at their processes, and could the same mistake have happened at another site that happened at one site? And so we're trying to prevent those incidences from happening.
And these presentations are not limited to adverse events. Many of them are near misses, where no harm was done, but we realized this could have turned out otherwise. So we learn lessons from things that maybe we could do better, even if there was no adverse event.
Yeah.
And also, coming off of just Quality Week recently, we really embedded just culture education again. So we're really, an individual can make a human error, and we want to make sure we console and, and if that was a little high risk, we'll make sure that we educate and take that right action. But if we're in the bucket that it's a blatant disregard, we're going to make sure that the right people are involved pretty fast to make sure that the hospital is safe, individual is safe, and then we are in turn picking up the phone and calling our system colleagues that are here to make sure that they know that we're in that category of we're concerned, and what actions do we need to take. And that really gets to the chair, medical director, medical leadership. But the just culture approach, we really try to look at the systems around any individual, provider or not, to make sure that do we need to tweak the system, work with Dr. Schwarz on policies if we need to tweak them as well. So really something that we stress here and use consistently.
This is great. Again, it's a very complicated process, and to implement it, it takes time and lots of patience. and ongoing education of medical staff and other support staff. So for you, Dr. Schwarz, what advice do you have for hospitals, medical chiefs?
So, as Dr. Salvador mentioned, this system didn't start off as a system. It started off as 21 separate hospitals. So each hospital has a medical director, otherwise other places refer to them as chief medical officers. And the first thing we do is we get all the medical directors together every month, so that issues that arise are discussed and approaches are standardized. And the medical director of each hospital is responsible for the day-to-day activities within those facilities. So one of the things we've done is we've been very careful to coordinate our efforts with the department chairs. And the metaphor I came up with that seems to resonate is I always tell the department chairs, you guys run the airlines, medical directors run the airports. And any airline that's going to land at an individual airport has got to work closely with the directors of that airport so that we're on the same page. So there's a lot of cross-pollination between departmental leadership and facility leadership. And as I said, the individual facilities meet on a monthly basis to make sure that we're all consistent with how we're approaching. We don't want something being done totally differently from one hospital to another within our system. The medical directors are intimately involved in the Credentials Committee. Medical directors sit on the Credentials Committee, and they are expected to speak loudly, vociferously about whatever they think is important within their building. We try very hard for everybody to read from the same hymnal in terms of getting data from the same sources, so that one hospital doesn't get information that another hospital does not. And we try very hard also to make sure that the privileges that are being asked for and the practices that are accomplished tally well with the system policies. And as Andrea mentioned, sometimes if we find the discrepancies, sometimes the policies need to be changed as opposed to the practice. We try to find out where the change is most effective. If there are any issues or any questions, then they are escalated rapidly to central leadership, Dr. Salvador or our Chief Quality Officer, Dr. Silver. So that's something, once again, we try to make sure that somebody in the central leadership is able to coordinate these efforts so that we're not doing things differently from one place to the next. The medical directors of each facility are responsible for supervising the FPP, the Focused Professional Practice Evaluation, and the OPP, which is the ongoing professional practice evaluation, to make sure that the chairs are in fact doing it and are providing the appropriate feedback to their practitioners, good, bad, or otherwise. And again, the medical directors coordinate to make sure that they've defined what the triggers are and how to deal with them. Also, medical directors are intimately involved in any of these key meetings. So if there's a root cause analysis, if there are corrective actions that are necessary, the medical director is supposed to be involved in those. And ultimately, if a large problem has been identified, and particularly if there are corrective actions that are identified, the medical director has the privilege of reporting on these events to the Committee on Quality, the Board of Trustees. So ultimately, what happens within a medical director's building is felt to be within that person's ultimate responsibility.
How about sharing information between the
Well,
sites?
this is something that, first of all, most of the medical directors have each other on speed dial, and there's constant communication, and how did you handle this, and did you have you dealt with this? So there's a lot of informal behind-the-scenes communication. But at these monthly medical director meetings, there's a deliberate intent to put on the agenda issues that we think might be, that were of concern in one hospital that we think are likely concerns at other hospitals, so that we learn from each other's experiences, both successes and failures.
This is great. So we have so much data, and Marianne, I'll ask you, what security measures you undertake to protect this information?
Yes, that's an enormous amount of information. First and foremost, it's protected under the quality assurance protections of the state. So all the information is protected. And I talked earlier about those competency assessment forms as well. The state affords privilege that so our colleagues that are filling out the forms know that this information is protected and is not going to be shared with the applicant, or so that they could speak freely if they have concerns of any applicants coming. As part of our NCQA certification, we actually have to do an audit of the credentialing database quarterly to ensure the users in the database, any changes to the database any changes, all the users are authorized, any changes were made by authorized users, and we have an audit process around that. We are fortunate today that our database lives behind our firewall, but we are next year moving into a web-based database, which again is going to raise cybersecurity concerns for us, but we have all the appropriate, securities in place for the software. We don't allow sharing of email addresses, so now everything's electronic, goes to the provider electronically. Talked about the competencies even going to the peers electronically, but you cannot share. It goes to the one provider, and they cannot share access to the database when they're filling out their paperwork as well. And also what we do when there's really sensitive information, PHI, maybe someone had a significant gap in their training or even in their background because of an illness, or maybe involved maybe a drug and alcohol problem. We protect those files, and we use a number when we present them to the credentialing committee and all the committees, so that when these individuals get through the process of working in the hospital, that we've protected that confidential information that confidential information that they might have disclosed to us, that we really don't want these large committees and medical boards privy to when it's highly sensitive as well. So those are some of the areas, but also we have phishing at Northwell, and our IT security is constantly phishing. I get a report as the manager of a department. My team is 85 strong, and I get a report ensuring that when those phishing emails come out, that they make sure that they acted accordingly on them. And if they didn't, I get a report and we speak to those staff members as well. So we do all we can do as a large organization into protecting our data and our database.
Well, thank you very much. Any last statement, Andrea?
Listening to the size of credentialing and how it's grown over the years, it's amazing on what you've done to standardize, reduce variation. The team comes on site twice a year to help review and educate our team on things we could do better here. And you're a wonderful resource to us at an individual site, but to the rest of the system, and now to the American College of Medical Quality. But it's really a remarkable process and effective process, and it's two-way, so it's really impressive in that way. And I've been to the board meetings, and I know they poke, and it's okay, because it's for the right reasons.
It's a partnership. It's a great partnership.
Yeah.
Okay.
So we can turn it over now to Skylar, who's going to go live with any questions you may have for us here at Northwell about our process and things we do here. So thank you very much for your attention, and we welcome the questions. Thank you. Hi, we're live in New York. Thank you, Skylar, for facilitating the video. And we're excited that we see one question already in the chat about overlapping of privileges and competency. So I don't know, Dr. Salvador, if you saw it, or Marianne or Richard, if you want to take that question.
So if the fellowship is required for the endoscopic procedures, one of two things, the medical staff office, if it's on the delineation of privilege form, we would advise the provider that they don't qualify for that privilege and they would be asked to withdraw it. Or the chair, when they see it, sometimes there could be minimum requirements, and if they do not meet the fellowship requirements or any requirements on the delineation of privilege form, the chair would speak to the applicant, and again, same process, ask them to withdraw it, the privilege, and we require withdrawal of privileges in writing, and we put that into the provider's credentialing file.
But basically, we require the credentialing based on the SAGE protocol.
Correct, the fellowships or the.
Very
yes.
important.
And if someone has acquired a skill following fellowship training, there is an opportunity to take courses and achieve certification subsequently, but there has to be some sort of documented certification of competence.
Right. But the bottom line, they have to fulfill the requirement, no matter what. Am I right?
Correct.
Okay. Abigail, do you want to make a comment on that?
No, I think Marianne summed it right. We usually put the requirements on our DOPs. We expect that the individuals who are applying have those requirements. If they don't have the requirements, we go back to the individual and we have those conversations, with them. In some cases, sometimes there are privileges that cross different departments, and where there may not have been an official like ACGME or other type of fellowship, and there's these independent fellowships. Then in those cases, we do then rely on the discretion of the chairs to ensure that that individual is competent, and based on often log numbers and volumes and the competencies that were filled out by the place where the individual was previously at.
I'll also add that if it's a GI privilege and it's not on the surgical DOP, we do a joint appointment. The FPP cannot be, if it's something that is primarily on GI, the FPP cannot be accomplished in the surgical department. We do the joint appointment. The two chairs would sign off the GI as well as the surgical, and then the FPP would be on the GI department side.
Happy to take additional questions. Okay. There's a comment. Thank you, Guy, again. The surgical requirements may not be as stringent as the American Society of GI Society.
That's why we do the joint appointment.
Yeah.
Typically, if it's not on the surgical DOP and it's on the GI DOP, because the fellowship is on the GI side, we do the joint appointment.
And sometimes when there is a privilege on multiple DOPs, we try to standardize the requirements for all the departments so that they're all being somewhat consistent.
But the FPP and OPP are the responsibility of whichever department has oversight over the documentation, over the certification.
Do we answer your question?
Yeah, I said yes.
Okay, I'm not sure if there's another question coming. Since we're a small group, we can, if you want to just unmute and ask, we're happy to take it.
We see a name, but no question.
I see a question. Do you have any tips for maintaining a just culture approach when outdated legal and or regulatory requirements are not necessarily in line with that? That's a great question. We're often dealing with in New York State regs that are quite old. Just had to deal one with the nurse practitioner. We were trying to identify in the pediatric realm the scope of practice and the age of population, where New York is, we'll say up to and about age 21. So they're not committing to 21. They're a little wishy-washy about it. But in many other states, it'll say that pediatrics can do up to 21, but in certain pediatric populations where the individual may not be in the traditional age group of 21, they may be a little older, but have pediatric illnesses that the pediatricians can care for those individuals. So individuals with congenital or genetic type of illnesses that have been treated by their pediatricians for years now have become 23, 24. And so often we're kind of caught in the middle of those legal and regulatory concerns. So we try to be a little scriptive in our DOPs so that sometimes if the state is a little wishy-washy about the definitions, we kind of try to define it a little bit better in our DOP. So then it defers back to either our DRPs or our bylaws, rules, and regs.
Right. But our frame of reference in this particular situation will be the diagnosis and the patient's condition. This is what overrules everything. And you're right. I mean, I recall that we did have some cases like this in the past. But if we felt that a pediatrician can provide the care more appropriately, then this would be what
Right.
we gave special privileges and we took care of it in that way.
And the DOPs get updated not infrequently as issues arise, as things change, as regulations change. The DOPs sometimes are added, sometimes are subtracted, and likewise our policies are updated at least every 2 years, but often more frequently if something arises that requires more immediate intervention.
Yeah.
This
But
one
we are
comes-
constrained with the New York like the laws, right? Because you have to follow the law. So what we do is we do work. In New York, we have certain organizations that we work with, like Greater New York or Haney's, and we try to advocate for those changes. And we reach out to the state to say, hey, have you seen this regulation? It's a little outdated now. You think can you update it? One example for us was when Joint Commission allowed for the 3-year cycle, the New York 405 regs in New York State still required recredentialing every 2 years. So we did reach out to our societies who we advocate for. We reached out to the state and said, hey, were you aware that New York, that Joint Commission now allows for reappointments every 3 years? And so they actually did go back, looked at their regs, agreed with us that it was still 2 years, still outdated, and they have now since changed it to 3 years. So again, when we see it, we do work with the state to try to update the regulations when possible.
This one reminds me, we do mock surveys for Joint Commission preparedness, and we always look at the bylaws and then the practice, the pap smears and the what was
Breast
it?
exams.
The breast exams.
I've been
The
trying to
New York
change
State
that one for years.
requirement.
Yeah.
And that's in the bylaws. So we point that out to the medical directors, and then we try to create policy around, you know, they can waive it, but if it's sometimes like an infusion under an Article 28 hospital license that really are coming in constantly, even H&P exam for an infusions, modify your policies for those ambulatory-based providers to ensure that you still meet the requirements of the state, or you carve out when it's just not realistic each time a provider's coming in. So a lot can also be modified by system policies, kind of crosswalking a little bit the bylaws, state requirements, hospital policies, things like that.
Right. There's more, or this is it?
That's a thank you.
Oh. No, maybe you should put the screen up and see if there is.
That's
No.
it.
Okay.
Well, we want to thank everybody for joining today. I want to thank my fellow colleagues for a wonderful panel that you provided, our producer Carly for always making great quality videos. And we look forward to our next one next year, which is going to focus on medical and nursing education and quality. Thank you so much. Have a good day.